Erasistratus in 300 BC to 250 BC. He is the first physician who described the heart as a pump. Now, when you say heart as a pump, it is surprising that it took so many years for us to develop an artificial pump, because pumps are so commonly used in the day-to-day living. Heart is one of the most stupidest organs compared to brain and liver, but it have taken more than 5 decades. 1966, Denton Cooley first started using some kind of a pump, but even till today we are suffering. We are unable to solve the problem. The different types of LVADs can be pulsatile or continuous. Pulsatile tries to mimic the nature. It is a displacement pump. It's called the first generation. The long-term use was there with HeartMate XVE. It is no longer used. It has valves. The next came centrifugal pumps or continuous pumps. There are of 2 types. One is the coaxial, that is the HeartMate 2, or the continuous centrifugal pump, that is the HeartMate 3 or Heartware. In the short-term use, one can use Impella in the cardiogenic shock patients, in the high-risk patients we use in the cath lab. Otherwise, the Centrimag, which is many times used in post-operative patients, and these both are valveless. Now, what are the first generation LVADs? As I mentioned, they are displacement pumps. That means just like a heart, they produce contraction and expansion. They are pneumatically or electrically driven. The Berlin Heart, XCAR, Thoratec, PVAD and XVE are the models. They are large size, they are producing a lot of noise, there are a lot of infection problems were there, malfunction because of the tears in the membrane and degradation of the valves. They actually failed over a period of time. This is a centrifugal pump. As you know, the centrifugal, as it spins, just like the centrifuge that you see in the laboratories, as the impeller spins continuously, a tangential force is created, so the blood is moves out from the circulation. So here in this particular HeartMate 2, it is an axial pump. It has got a propeller pump. Can you get it off, please? The heart, this is axial. In the HeartMate 2, it is an axial pump, coaxial. It is like a propeller. It has got a spinning motion, and that will produce the movement of the blood from the inlet to the outlet. The HeartMate 3 is the centrifugal pump. In this, as I mentioned, both Heartware and HeartMate 3 are the models of this. One, it has got a stator, which is an electrical motor, which is connected to a rotor. In axial pump, there is a bearing which will cause the movement of the fluid, which will cause the rotation, kinetic energy to the blood. Whereas in Heartware and HeartMate 3, it is a magnetically levitated. So there is no contact between the impeller and the rotor. Because of the magnetic force, the impeller will be moving continuously at 3,500 to 10,000 or whatever the set speed. That produces centrifugal force, and the blood comes out tangentially. Because there is no contact, there is no wear out. They are very small, and they are considered at least maybe durable up to 10 years. And in HeartMate 2, there is no pulsatile flow. Whereas in HeartMate 3, a pulsatility can be produced because of the spontaneous changes in the RPM. The pulsatility, as we see for later on, is very important in the long-term safety of these LVADs. They can pump up to the 10 liters of the blood, and because of the pulsatility, there is slightly decreased tendency for the thrombus formation. Here you can see on the top, you see in the A, on the left-hand side, you see the auxiliary pump. There, on the pictorial diagram, the inlet is connected to the LV apex. It is connected to the axial pump, and there is an outlet which goes on to the aorta. There is a drive line which comes out through the skin, which is connected to the batteries. The batteries have to be kept ready or changed, or in the night they can be charged to the AC port. Now, in the lower side, you see the HeartMate 3. It can be small, that is about 450 grams or something. It can be kept in the hand, very smaller one. And as I mentioned, it has got magnetically levitated motion. Now, where do you use LVAD? It may be used to start with. They start using for as a bridge to transplantation in very sick patients who are dying. When the patient is waiting for transplant, they were using it, or a candidacy. Like, for example, if the patient is not ready because of the end organ dysfunction or especially pulmonary hypertension, you can use this LVAD. Once the patient recovers partially, at a later date, he may become a candidate for heart transplantation. Or it may be a destination therapy, because as the aging population is there, where transplantation is not an option, where the lot of comorbid conditions are there, as a destination therapy, LVAD can be used. A bridge to recovery, for example, in patients with myocarditis, sometimes it can be used, but it's more of a retrospective than prospective. You don't know which patient will improve. Maybe less than 5% of the patients may improve, recover their LV function, and gradually one may wean off and remove the LVAD. What are the indications? The indications are frequent hospitalization for heart failure, intolerance to neurohumoral antagonists, functional class 3 or 4, end organ dysfunction, increasing diuretic requirements, CRT non-responders, inotrope dependence. And the absolute contraindications are irreversible hepatic, renal, and neurological diseases, and patient is poor compliant. Compared to the transplantation, what are the exclusion criteria? If the body size is less, you cannot put LVAD. If the age is not a criteria, any age you can put, whereas the heart transplant, you have a limited age group. If the PVR is more than 3 UD units, you can still go ahead up to 8 units for LVAD. RV function, if it is dysfunctional, LVAD can give a problem because the patient will develop right ventricular failure, acute right ventricular failure. One has to be careful. The urgent situation is not a contraindication, whereas urgently you can't do a heart transplant. The comorbidities, malignancy is a contraindication for transplant, whereas it's not a contraindication for LVAD. Similarly, as I mentioned, pulmonary renal, we are little more liberal. And on the other hand, if the person has got restrictive cardiomyopathy or cannot tolerate anticoagulants for whatever reason, one cannot use LVAD. Here in the graph, you can see on the top, the red line shows the heart transplant. At the 24 months, the survival is 84%, whereas the optimal medical therapy on the lower side, that 24 months, the survival is 8%, whereas the LVADs that are closer to the heart transplant, 2-year survival rate is almost 60%. As I mentioned, pulsatile LVADs are out of vogue. In this particular trial, actually at the end of the trial, all the pulsatile LVAD patients converted to continuous flow LVADs. Now, as I mentioned, the HeartMate 2 and HeartMate 3, this is a momentum trial which is published, I think, January this year. The centrifugal flow pump, that is the HeartMate 3, the 6 months event rates are much less compared to the HeartMate 2 axial flow pump, because the axial flow pump tends to lead to the non-pulsatile flow that lead to the complications like thrombus formation, IT regurgitation, and GI bleeds. All these things will add to the complications. The event rates are much less in the HeartMate 3, which has got inbuilt pulsatility. Now, the same thing, Heartware is a different company. Even here, the 3-year survival rate is about 73%. And one has to calculate when you put LVADs, one has to calculate the risk. Some of the patients, if you do it very late in the patient's heart failure sickness, patient may not do well. There are 2 particular risk sources mentioned here. We are taking into account the albumin, creatinine, INR, and the center's experience, age of the patient, platelets, so many risk factors. These 2 risk factors sources are there, based on which you can decide whether the patient can go for LVAD or not. The major complications are bleeding, cardiac arrhythmia, infection, respiratory failure, stroke, aortic regurgitation, and most of the deaths are because of the neurological events or multi-organ failure because of the thromboembolic or bleeding complications. Device malfunction occurs uncommonly in about 3.5% of the patients. Whenever you put LVAD, you have to be sure that the patient may not develop acute right heart failure after putting left ventricular assist device. So some of these criteria are here, like RV function, or preoperative creatinine levels, or previous cardiac surgery. They are all predictors of the acute right ventricular failure. Intermax level, any cardiologist interested in heart failure should know all these things. The class 3 to 4 is not simple entities. There is a spectrum. This is the Intermax spectrum is class 1 is crash and burn. The patient is acutely sick, cardiogenic shock, he is dying. The class 2 patient, Intermax level 2 patient is sliding fast. He is a progressive decline. He is on inotropes but declining very fast. His survival is days to weeks. The level 3 is stable on inotropes. He is dependent stability. He is stable but on the inotropes. A frequent flyer is who frequently comes to the hospital for inotropes. Housebound is exertion intolerant. He can't tolerate any exertion. And level 6 is walking wounded, very limited exertion. And stable class 3 is placeholder. So in the Intermax trial, if you see the levels, level 1, 2, 3, mostly the LVADs are used. Level 4, 5, 6, they are less often used. And progressively, we are moving towards using LVADs at a earlier stage. Here you see the Intermax level 1 to 3, 2-year survival is 60%. Whereas if you put the LVADs in a less sick patients, like Intermax level 4 and above, the chance of survival are better. In this trial, roadmap trial, when the LVADs are implanted in Intermax 4 to 7, that is the less sicker patients, most of them, the survival, there is not much of difference at the end of 12 months, but most of them had a better function class. So the trend is now to use HeartMate 3, a centrifugal pump with intrinsic pulsatility, and to use them in a less sicker patients. Thank you very much.